Hello friends, my name is Ankit. I make educational videos on US healthcare. I'm back with another video on Da Vinci Risk Adjustment FHIR Implementation Guide. If you are new to my channel, welcome. If you regularly watch my videos, I want to thank you for your support. Please like and subscribe to my channel for future updates. Talking about Da Vinci Risk Adjustment FHIR Implementation Guide, this guide will enable standard exchange of risk-based coding gaps among stakeholders such as payers, providers, and government care program in support of driving towards accurate and complete documentation of health conditions that would lead to more accurate risk adjustment payment calculations, reduce administrative burden, and improved quality of care. Health risk is a combination of two factors, loss and probability. Many players in the healthcare industry need to measure and manage health risk. For example, providers need to know which patient in their panel are facing the greatest clinical risk to prioritize their care. Insurance payers need to know the expected financial risk of their covered lives so that they can price their premiums appropriately. The risk adjustment models are used to compare and normalize health risk scores, groups, or population. For instance, the Medicare Advantage MA population represents a risk pool, as does the subset of MA population that Payer X covers. One common use of risk adjustment is to make equitable comparisons among healthcare payers that take into account the health status of their enrolled members to provide adequate financial support for treating individuals with higher than average health needs and to minimize incentive for plans and providers to selectively enroll healthier members. Risk adjustment models determine whether payer X's risk pool represent more or less health risk than the MA population average, or that if a payer X is running a greater risk, say because its risk pool includes a greater portion of economically disadvantaged persons, then appropriate payments are made to help ensure that these member premiums are subsidized to offset the higher expected cost of claims that payer X will incur. The risk adjustment is used for this purpose within Medicare, Medicaid, and the Affordable Care Act, as well as other health insurance programs. Risk prediction models have a different intent. They are used to predict the future behavior of individual or population, such as who is likely to be a high utilizer of healthcare services or who is likely to experience adverse healthcare events. This is an example of MA risk adjustment. Now, of course, the same risk adjustment activities, they happen year over year. So the risk adjustment activities in support of these payment cycles concurrently overlap during any given year as shown in the figure. Note that the figure shows the Medicare Advantage risk adjustment cadence. Other programs such as Medicaid and ACA follows a different annual risk adjustment cadence. But in this scenario, there are three main activities that the risk adjustment activity is tracking for the MA risk adjustment year-on-year basis. That includes member encounter data collection and sweeps, data collection and payment adjustment, and submission deadline where these risk adjustment calculations need to be submitted to the appropriate authorities. After careful review, the risk adjustment subject matter expert, it was determined that the most challenging aspect of the current risk adjustment process was the inconsistent manner in which reports on risk adjustment coding gaps were communicated between a provider or system operating on their behalf and a payer or a system reporting on behalf of payer. The figure 1.2 shows a high-level example of the risk adjustment workflow in CMS Medicare Advantage program. This version of the implementation guide focuses on specifying a standard exchange format, the risk adjustment coding gap report from payer to provider. This diagram does not depict preceding steps such as payer receiving clinical or claims data from providers or other sources, nor does it attempt to define contractual relationships. The MA population workflow, it starts with the regulatory authority such as CMS, which is also known as Center for Medicare and Medicaid Services. CMS allows payers to offer MA plan. The payer, as part of phase 1, payer sends the risk coding report to the provider group. The provider group may schedule a visit with the patient. The patient comes in and the appropriate codes are captured regarding the risk categories. The provider submits the accurate diagnosis to payer. The payer sends the codes to CMS for use in calculating appropriate monthly. Now, the actors in this process that are involved are clients and servers. Clients are the actors requesting risk adjustment coding gap reports using the report operation. Servers are the actors receiving the request for retrieving the risk adjustment coding gap report using the report operation. In the example shown below, a payer acts both as client and server in this scenario. The payer acting as a client calls the report operation on their server to query matching risk adjustment coding gap report based on the parameters provided in the operation. Then the payer posts the report to the providers. In the next image, the client calls a report operation that is defined in this IG. The server then queries matching risk adjustment coding gap report based on the parameters provided in the operation and returns the report to the client. Overall, the focus of this process is that we need to understand the risk associated with providing coverage to certain populations. Population where people are at risk for their coverage. Population where the cost of coverage will be very high. If these are federally or state sponsored program, the payer will be at advantage if they can ask their providers to do the risk assessment for their population properly. So not only the payer will be able to look at the premiums more closely and come up with appropriate premiums for this patient, but in certain government sponsored subsidized program, the risk assessment report can be submitted to the government authorities so that the payer can be subsidized if they are incurring huge expenses for covering this high risk population under certain government programs. Hope you liked today's video. Look forward for your feedback and comments. For additional details, please feel free to refer the Da Vinci risk adjustment FHIR implementation guides. See you all into the next video. Until then, see you next time.